Professor Van Gelder, it's a pleasure to meet you. So you presented the results of the Race 3 trial today. Are you able to tell us a little about what the trial was about?
Well, thank you. Thank you for the invitation. Indeed, Race 3 was started because we all know that restoration and maintenance of sinus rhythm is so difficult. And what we also learned during the years is that there is a remodeling process which starts long before the first episode of atrial fibrillation occurs. And we know that upstream therapy exists. And upstream, I mean preventive therapy to prevent recurrent atrial fibrillation that not acts on an action potential, there's not an antiarrhythmic drug, but acts on the atrial substrate itself. What we know is that primary prevention for the first episode of AF in heart failure and hypertension patients is effective upstream therapy, but it has never been demonstrated to be effective for secondary prevention after a first episode. And that was why we wanted to do the Race 3, and we started the trial almost 10 years ago. We also included lifestyle. That was a little bit new at that time, so physical activity and reduction of weight and sodium restriction. So actually we randomized our patients to conventional therapy or upstream therapy, and that included 4 strategies. The use of MRAs, mineralocorticoid receptor antagonists. We gave that for anti-inflammation effects, not for.
Sure.
And maybe it also helped for as a diuretic and for blood pressure lowering.
Yeah.
And we started statin, also for anti-inflammation. And we started ACE inhibitors and ARBs for antifibrotic. And then lifestyle, so reduction of weight, physical activity. So that was our upstream treated group, and it is a superiority trial. Our hypothesis is that upstream is superior to conventional therapy, and to assess that, to study that, we wanted to include patients who were a little bit sick, who had a little bit associated conditions. So we went for persistent atrial fibrillation, not paroxysmal.
Yeah.
They are often too healthy. They can also easily nowadays be treated with ablation.
Yeah.
We included persistent AF, but with a very short duration, total duration of AF. The total duration of persistent AF had to be less than 6 months. So that is much shorter, as is investigated in prior trials.
Yeah, sure, absolutely.
So in the end, in our baseline characteristics, the total AF history is a median of 3 months in both groups. The total persistent AF history is 2 months. And those patients who we wanted to include must have heart failure, either reduced ejection fraction or preserved ejection fraction. And also the duration of heart failure as associated comorbidity, and HFpEF, as you know, is often caused by hypertension. And also the duration of the underlying heart failure condition had to be less than 1 year. So really short-lasting AF with a short associated condition.
And did these people have so you said they didn't have any therapy which affected the action potential, so none of them would have been on amiodarone or conventional antiarrhythmic?
So it were really new patients, and therefore it took us long to include all our patients.
Yeah. And were they on any rate control to start with?
Well, we included persistent AF, and they had to be treated for atrial fibrillation and for the associated diseases before we randomized them. So they were in atrial fibrillation, so they were put on rate control before. And
Okay, and how were the results?
Well, the results and the primary endpoint is sinus rhythm maintenance at 1 year follow-up during 7 days of Holter monitoring.
Wow, okay.
So that's rather long. Nowadays,
and for a persistent group as well,
and nowadays, of course, we have the implantable loop recorders and so on, but we choose for 7 days Holter at 1 year, 75% of our patients in the upstream, and 63% of the patients in the conventional group. And that was statistically significant different.
In AF or
in sinus rhythm?
We're in sinus, wow. Okay.
So the high percentages, even in the conventional group, but it might relate to the fact that we included the patients so early after onset of AF. And it was in fact a risk factor driven upstream therapy. So we wanted to to improve sinus rhythm maintenance, but we also wanted to reduce the risk factors. And indeed, in association with the reduction of the higher percentage of patients maintaining sinus rhythm, we saw a larger reduction of the blood pressure, systolic and diastolic in the upstream group. NT-proBNP as a marker for severity of heart failure was significantly lower in the upstream group, and also LDL, because we instituted statins. Was lower. In both groups, the ejection fraction improved, but there was no difference between the groups. BMI did not change, and that might relate to the fact that we did not include very obese patients. Only 1/3 of our patients were obese. The median was 28, and there were also patients not obese at all. And maybe our counseling for that was not strict enough. That might be because we only counseled our patients every 6 weeks. And for example, if you compare our counseling with the group of Presh Sanders, he counsels 7 days a week, 24 hours. Counseling is possible, so that was very, very aggressive.
And and I guess because the BMI wasn't relatively high.
No,
these patients generally wouldn't have been offered obesity surgery, for example.
No, certainly not, because no, that was not the case at all. And I think also it shows. Our physical activity and cardiac rehabilitation program included physical activity, but also diet and also salt restriction. And I think. From the fact that we didn't find any difference in BMI, you cannot say that cardiac rehabilitation was not effective, because physical activity might have been effective, and we know something as the obesity paradox, and maybe patients who are physical active, it may also have been advances, may also be added to the reduction of maybe of value for the reduction of blood pressure.
No, absolutely. And was there much crossover from your treatment arm? Because were there people who became so symptomatic from their AF that they needed to start amiodarone or cardioversion?
Well, both groups were treated with according to the rhythm control guidelines. So electrical cardioversions were performed in both groups. Repeat electrical cardioversion. And also institution of antiarrhythmic drugs occurred in 40% of the patients in both groups. So, but in the end, in the upstream group, despite the institution of antiarrhythmic drugs, also in the conventional group, significantly more patients were in sinus rhythm.
Yeah, no, absolutely.
But they all were treated according to the AF and HF.
But the intention was with the upstream group is to try and avoid the antiarrhythmics.
Well, just it was an add-on. So they were treated. Both groups were similarly treated, with according to the AF and HF guidelines, and then on top of that, the 4 strategies were added in the upstream group. And of course, it would have been nice, of course, if those patients did not need a cardioversion, but that was not the case. And maybe that is also too much. Maybe then we have to start even earlier.
Absolutely. And then you're almost dealing with a paroxysmal group, aren't you? So in the conventional therapy arm, what was kind of a typical regime the patients would be on?
Well, those patients that went for recardioversion and antiarrhythmic drugs, like we used to do it, and in 1 year follow-up, only a few went for atrial ablation in both groups. So because I think the follow-up was too short to be scheduled. We also will present, hopefully in 4 years' time, our 5 years results. Maybe then we can see that the atrial ablations occurred at a significantly lower rate in the upstream group. We do not know. But those conventional treated patients were at least treated with rhythm control comparable to the upstream group.
And how many patients were included? I didn't ask you that at the beginning.
250.
In total or in each arm?
No, in total.
In total, okay. So what are the plans? So now you're planning to do a 5-year analysis as well?
Yeah, we think for upstream therapy 1 year follow-up maybe too short. So we will have a look at 5-year follow-up. The problem with 5 years is, will those patients stick to their upstream
So that counselling won't continue?
Not as strict, or not every 6 weeks. That's always the problem. And but now, of course, we also in the Netherlands, because most of the patients were included in the Netherlands, there were also 3 UK centers. Sure. And maybe we will make some promotion for the race 3, and maybe the patients also want to continue easier.
Well, I guess you'll be offering some of those upstream therapies to the conventional arm as well now. They'll continue on the conventional arm.
Well, I don't think. Well, what the clinical implication is of this study, I don't think you can say you should treat all those patients with those 4 strategies. That might be too much.
Yeah.
The clinical implication really is that we better should assess underlying risk factors, better treat the risk factors. And for that we really need an AF clinic with nurses dedicated to look at the blood pressure and to ask also for other triggers and risk factors for atrial fibrillation and treat it as good as possible, because we are not good enough to treat blood pressure low enough.
And you mentioned that, I mean, the aim was really trying to affect the substrate.
You're right.
Are there any plans to kind of try and understand the substrate in these patients? Are you going to MRI any of their atria to see what the fibrosis burden might be in one group versus the other? Or?
Yeah, that would have been perfect, but we did not do it.
Or even doing it now, like a year after.
Yeah, whether there's a difference, but then you do not have the baseline.
No, sure.
Is well, actually, we assessed the left atrial size and the left atrial volume, but there was no difference between the groups. And but maybe the technique was not good enough because we did not have an echo core lab for this study.
The resolution may not be as good as.
Maybe, and maybe also we were already too late.
Yeah.
That it are more the risk factors that we were treating than the substrate. We do not know, but that might be the case.
Okay. Well, I think these are exciting times in the management of AF. We've seen some other very important trials at ESC here, so very interesting to hear these results. It's been a pleasure.
Thank you very much for the invitation.